Okay, I'm going to go through the skull foramina. I always like to start off by splitting it into three parts: anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Anterior cranial fossa is composed of the frontal bone as well as the ethmoid bone. Middle cranial fossa has the sphenoid bone with its greater and lesser wings, and the temporoparietal bone as well. And then the posterior cranial fossa has the occipital bone encasing the posterior lobe. Anterior cranial fossa has the foramen cecum right at the front. This transmits an emissary vein from the nasal cavity up into the superior sagittal sinus, and is important if you have infections from the nose directly into the intracranial component. Then we have the foramen cecum, the cribriform plate with the ethmoidal bone and the crista galli, and this transmits the olfactory nerve, which is important for smell. Also, contusions here or frontal intracranial injuries can lead to CSF leak down into the nasal cavity. Then the middle cranial fossa is really where it's at. The hole right at the front is the optic canal. This transmits the optic nerve as well as the ophthalmic artery, and they come out at the posterior aspect of the orbit. Adjacent to it and running in three structures essentially is a superior orbital fissure, foramen rotundum, and then the foramen ovale, and they always come like that, standing room only. So the superior orbital fissure is important because it transmits the branches of the ophthalmic V1, and that includes the lacrimal, frontal, and nasociliary. And then it has the nerves that supply the movement of the eye muscles, which are 3, 4, and 6, oculomotor, trochlear, and abducens, as well as a superior ophthalmic vein as well. It's important to establish sometimes with superior orbital fissure versus orbital apex, you get loss of sensation to the forehead, ptosis, and issues like that, whereas the orbital apex syndrome, you have ophthalmoplegia, loss of red light vision that differentiates the two. Next one down is the foramen rotundum, big round thing that transmits the second part of the trigeminal nerve, the maxillary division, and this then goes into the pterygopalatine fossa, so important because it comes out the other side, and that's why it's important through there. Third one is the foramen ovale, and that has you can use the mnemonic ovale for the otic ganglion, the V3 component, which is the mandibular branch, accessory meningeal artery that actually comes back up through the maxillary artery, lesser petrosal nerve, which is actually a branch of the glossopharyngeal, and emissary veins that also come back up. Right next to it, little tiny round thing, foramen spinosum. I always think of this as the mixed martial arts foramen because it transmits the middle meningeal artery, MMA, and also the meningeal branch of the trigeminal, which comes back up. But important that any blows to the side of the head at the pterion, where the frontal, temporal, sphenoid, and parietal bones meet, can knock out the anterior branch of it. As it comes out, it gives out an anterior and posterior branch and runs in the groove respectively. And then lastly is the carotid canal. Right next to the carotid canal is actually the foramen lacerum, which then fills up with cartilage. But the carotid canal comes out and transmits, of course, the internal carotid artery. What's important is it has a transverse and then an ascending component into the cavernous sinus. The foramen lacerum is important because it actually gives rise to the greater petrosal nerve and transmits that, and that's important. A bit later on, we can discuss that. Now moving on to the posterior cranial fossa, go straight for the big boy, the foramen magnum, where the medulla, vertebral arteries, and the spinal roots of the accessory nerve come up. And then there's the jugular foramen, and I always think of this as the 911, so it transmits cranial nerves 9, 10, and 11, as well as the inferior sigmoid sinus and petrosal sinus, inferior petrosal sinus, and sigmoid sinus to then give the internal jugular vein. And right here is the hypoglossal canal that obviously transmits the hypoglossal nerve. Above it is the internal acoustic meatus, which has the nervus intermedius, vestibulocochlear nerve, and the facial nerve that then travel. And the facial nerve then, with its nervus intermedius, gives out its first genu, the ganglion, the deep petrosal nerve, which then exits through the foramen lacerum into and joins a branch of the deep petrosal nerve, which is actually coming from the internal carotid nucleus, and then forms the Vidian nerve and goes through the Vidian canal into the pterygopalatine fossa, and then later goes on to supply the lacrimal gland via parasympathetics, as well as the mucosal aspects of the nasal cavity. Just looking at the broad base of it here, the hard palate has an anterior 2/3 component and posterior maxillary, and then posterior palatine third bone, and there's a greater palatine foramen and the lesser palatine foramen. So the pterygoid hamulus as well, that has important muscle attachments of the tensor vela palatina that goes round, hooks round that, and then forms the other side into the palatine aponeurosis. And this is the posterior nasal spine as well. And then the stylomastoid foramen as well that comes out, and you can see this is the external acoustic meatus, stylomastoid foramen through there as well. And the exits signifies the exit of the facial nerve, and you can see the styloid process that protects it as well and has important attachments and landmarks.